Hi, so this is just a short lecture about paraphilias, which are adult disorders. And so they're not all paraphilias, but most of them are that we're going to talk about. So gender dysphoria, gender identity disorder is actually not considered a paraphilia, but it's when there's gender incongruence, meaning that the person feels that they are a gender that is opposite of what they physically are. And so we don't want to confuse this with cross-gender identification or transvestic fetishism. These are all different things. So the person desires and feels as though they are the opposite gender, and so they may dress differently or alter hormones or even surgery. And this can be very distressing. We actually see a lot of patients that have gender dysphoria. A lot of times they come in because they are, suicidal or severely depressed. Paraphilias. So this is the majority of what we're talking about right here, and this is the only time in the program that you discuss these. So these are an intense, persistent sexual interest other than sexual interest in genital stimulation or preparatory fondling with phenotypical normal, physically normal, and consenting human partners. So these are things that are usually, out in the fringes, and they tend to cause distress to either the person or the person that is receiving these. Receiving this attention is non-consenting or not an adult. Etiologies and treatment. So again, it's a theoretical integration. So a combination of biological, psychological types of potential causes and treatments. So there are thought that there's an abnormal level of androgens, which is like testosterone. And so that person would be treated with anti-androgenergic medications. And then sometimes even chemical castration and or therapy. Psychological, so sometimes the perpetrators of certain types of sexual violence have actually been a victim of such sexual violence when they were younger. So some of these behaviors may have been role modeled, and they've learned from it. For me, that's the one thing I try to remember, that a lot of times when I'm working with people with pedophilic disorder or other types of disorders along these lines, is that a lot of times they were the victim of these disorders themselves. So it at least helps me to empathize a little bit, because sometimes this is a patient that is very difficult to connect to, especially when it's pedophilia. And when we think about psychologically, what happens is that we know that rewarding conditions behavior, and sex in and of itself is gratifying and rewarding. So the person may try something out initially just out of curiosity, and because it was gratifying, then the person continues it, and that's how it can become, something like a fetish. Voyeurism, things like that, and the person just repeats it because it is gratifying. And what can happen is then that can really end up being kind of the sole way that the person is able to receive sexual satisfaction. So application of the nursing process to clients with sexual disorders. So self-assessment, again, this is the type of patient that can really bring up some conflicting emotions in the nurse. And so we need to make sure that we're doing that self-assessment, making sure that we're non-judgmental and we display acceptance of the person. Remember that you don't have to accept somebody's behaviors to treat them as a human. We want to start open and follow the client's direction. We should be asking everyone about their sexuality and making sure that we're open and objective. For these particular diagnoses, A nursing diagnosis that we'll often use is ineffective sexuality pattern. There's also one that has to do more with like sexual dysfunction, but that doesn't really fit with these as well. Planning outcomes, we want the client to resume sexual activity at a level satisfactory to self and partner, and the client will express satisfaction with own sexuality pattern. Interventions, so we are supportive of this patient. We maintain and reinforce appropriate social boundaries, and we need to make sure that those are very clear because, again, depending on which paraphilia the patient has, these boundaries could be pushed. Tension reduction, so we do allow patients to use tension reduction, especially if they are hospitalized long-term or someplace where they're committed. We do have to allow for some privacy for that. Feelings associated with behavior or preceding behavior. So we want to help the patient to figure out what those triggers are. What are those feelings? Are there feelings associated with the behavior afterwards or beforehand? And recognizing the consequences of the behaviors, that it affects other people. And a lot of times that's why people will seek help, is because not just because of their own dissatisfaction, but because their partner may be dissatisfied or they get into legal problems because of it. Pharmacological and therapeutic interventions. So, there could come a point where chemical castration could be necessary. It's ordered by a court. And psychotherapy or one-to-one discussions or even group discussions. Patients could go through desensitization. They could be taught about masturbation or fantasy sex so that they're not actually performing the acts that are causing distress. And the nurse can make general assessments and suggestions, but this may often require more specialized intervention, so an actual sex therapist. Evaluation, we reassess the patient overall. Can the client verbalize stress and identify different ways to cope? Are both the client and the partner experiencing satisfaction? And does the client have an increase in self-worth? So the back part of it's just matching. If you haven't done that yet, go ahead and pause it now, but I'm going to go through the answers. So the matching is number 1H, 2B, 3F, 4C, 5G, 6A, 7D, and 8E. Thank you.